psychiatrist, practicing psychiatrist based in Singapore. I must admit that while seated at the back of the lecture hall, I was very overwhelmed by how advanced cancer research has evolved over the years, and all those things about things research on a molecular level really overwhelmed me. For this talk that is just before lunch, I would take things beyond the molecular level and shift it more to a patient-based level. So, as mentioned, this is something that is bread and butter in psycho-oncology, an evolving branch of medicine that deals with oncology patients with psychiatric or psychological needs. For this talk that I'm giving, I'm just going to give a brief overview about issues of psychiatric illness in the cancer patient, and I hope to achieve the following. First and foremost, give an overview of common psychiatric illnesses in cancer patients. I believe this will be very important for practicing clinicians. Differentiating psychiatric illness from psychological responses. I mean, when is sadness beyond sadness and goes more into depression that needs treatment? And thirdly, after that, I'll talk a bit about treatment considerations for psycho-oncology patients. So, a diagnosis of cancer often evokes a maelstrom of emotions in the cancer patient. And this often forms a spectrum from normal emotional reactions. A lot of times, the patients will start to worry about many things, such as mortality, morbidity, and there will always be a lot of anger, like, why me? I was very healthy all my life, I didn't smoke, I didn't drink, how am I suddenly stricken with this very deadly disease? A lot of times, there's also be a lot of apprehension and guilt about causing a burden to the family members, and along with it comes the feelings of hopelessness and helplessness. So on one end of the spectrum, we do have normal emotional reactions. On the other hand, we do have a more severe form, which would be the psychiatric disorders. These would commonly be depression, or something known as major depressive disorder, anxiety disorders, delirium, and neurocognitive disorders such as dementia. So it is at this point in time, I think it is very important to debunk some myths that I see very common in my other oncology colleagues. So they come across a cancer patient who has a little bit of fear, and they will think that, well, it is all right for a patient to be rightfully anxious. And sometimes they see a patient who is extremely sad about his or her current circumstances, and they feel that, well, it is actually rightfully, this patient is actually rightfully depressed, and hence we should not really do anything about it, all right? I beg to differ, because I feel that there is a huge difference between normal emotional reactions and psychiatric disorders. With this slide, I'll try to attempt to explain to you the importance of differentiating one from another. So, if we do have a patient with untreated psychiatric illness, there will be a lot of implications. First and foremost, there is increased mortality, and we also worry about suicide. Thirdly, is also the prognosis of cancer, because from my understanding, the prognosis of cancer is mediated by an alteration in the cellular immune response, and this could be a decrease in natural killer cell activity. And if a patient is depressed, these things are affected, and this worsens the outcome of cancer for the patient. Lastly, if psychiatric illness is untreated, this would lead to a negative impact on the quality of life for the patient. On the other hand, if we are overzealous in labeling every patient with an emotional reaction as having a psychiatric disorder, there will also be many other implications as well. This will be covered under the other column, the implications of false positive diagnosis. First and foremost, there is unnecessary treatment. The cancer patient already has to go for cycles of chemotherapy, and if you falsely label his reactions as one that is seen in a patient with depression, you end up treating him with antidepressants, you end up giving him a whole host of appointments with psychiatrists and therapists, and this would certainly affect the patient's quality of life. Along with it, no medicine is free of side effects. Chemotherapeutic agents is one, psychiatric medicines is another. So if we treat the patient unnecessarily, we expose the patient to unnecessary side effects of treatment as well. And thirdly, there are things like stigma. a lot of patients feel very stigmatized with the diagnostic label of depression. They feel that people would think that they're being weak and they can't overcome the adversities of their life. And because of that, this also leads to a negative quality of life. And fourthly, there's also additional cost, not just to the patient on patient level, but also to the healthcare system. So, because time is limited and I'm dangerously approaching lunchtime and we're already tired and hungry, I'll just talk about two conditions that I commonly encounter in my practice, working in a tertiary hospital that deals with a huge proportion of oncology patients. The first one is major depressive disorder, commonly known as depression. So let's talk a little bit more about the diagnosis of major depressive disorder. At least from where I am based in, we follow the DSM diagnostic criteria, which is established by the American Psychiatric Association, and it is seen on the left. Excuse me for the fine print. It looks like a really busy slide, but just to make it a little bit simple for you, essentially, major depressive disorder can be conceptualized, the symptoms of it can be conceptualized into two major categories. One would be the physical symptoms, and another would be the emotional symptoms. So physical symptoms will include things like feelings of lethargy, fatigue, sleep problems, sometimes they sleep too much, or sometimes they get insomnia. GI disturbance, meaning they do have tummy problems, bloatedness, loss of appetite, anorexia. Psychomotor changes, meaning they may get irritable, or they may get very apathetic and evolutional. Emotional symptoms would be more in the realm of depressed or pervasive low mood, a loss of interest in everything. So previously, you may have a patient who was very passionate about life, who loves to volunteer, who loves to sing, who loves to dance, but because of major depressive disorder, the patient just stops doing all these because he or she feels that there is no purpose in doing that anymore. So other emotional symptoms would be concentration difficulties, guilt, worthlessness, and this is something that I'm most worried about would be suicidal ideation. So, as mentioned earlier on, I hope to sort of give you an idea of how we can best differentiate between normal sadness and depressive disorder. So let's talk a bit more about the physical symptoms of depression. So I think in patients with cancer, it would be very important and we should be quite cautious in not labeling a patient with sadness as depression. And we should not over-rely on the physical symptoms of these patients. This is because the physical symptoms of depression in these patients is not always due to depression, but could be due to the cancer itself. For example, loss of appetite. Is it because the patient is too depressed to eat? Or is it because of the nausea and vomiting that the chemotherapy brings about? Likewise, if a patient complains to you that he or she has insomnia, is it because she spends her night worrying excessively about things? Or is it because there's unrelieved pain from the tumor? So, as much as the DSM diagnosis, as I showed in the earlier slide, gives a list of criteria to look into, it is very important for the clinician not to rely on a checklist approach, but to explore with the patient deeper into what the symptoms means to him or her. So if physical symptoms are not that valuable in helping us differentiating depression from normal sadness, then what about emotional symptoms? So in my view, I think it is perhaps more important for us to rest our diagnosis, our clinical diagnosis, upon these other emotional symptoms. As mentioned earlier on, this will be a loss of interest. In patients with normal sadness, even though they may have lost interest to some of the things that they usually love, to a certain extent, they would still be able to react positively to activities that they enjoy, even though the range of these activities to them may be diminished because of the effects of the cancer. So in depression itself, these patients will have such profound loss of interest that almost all, if not all, activities would not be able to brighten them up. In hopelessness, we see that in patients with normal sadness, even though they may have an understanding that there may not be much cure for them, and there may not be much hope for them for recovery, they would still have this hope that they have that their life can be extended by maybe 1 month, or maybe 6 months, or even a few days, and that the symptoms can be better optimized such that the quality of life can be maintained. In the case of depression, the hopelessness is a little bit different. The hopelessness will be more pervasive, and it would usually be accompanied by a sense of huge despair and despondency. In terms of guilt, the patients with normal sadness, may feel that they are burdening their families unfairly, whereas in depression, the patients would feel that their life has never had any self-worth, and they may feel that they're actually being punished for all the evil things that they have done in the years preceding. So I know this is really quite a difficult thing to diagnose, depression, because it really requires you to sit down with the patient. You probably need about 30 minutes to 60 minutes at least to talk to the patient to understand his or her problems better. So for the busy clinician, I'll recommend you using this PHQ-9 questionnaire. It is readily downloaded from the internet, so it's free of charge. You don't really need to administer it because it's patient administered. All you have to do is to hand this piece of paper to the patient, and he will go through the list of symptoms, and he will grade the severity of the symptoms. After that, you just need to tabulate the total score, and if the score hits a certain point, you would then consider and worry about clinical depression. So, I've talked a little bit about diagnosing depression. How about management? In psychiatry, we always believe that the mainstay of psychiatry, or what characterizes psychiatry, is collaborative care. It is also known as integrated care. What it means is that we need a multidisciplinary team of individuals. This could comprise the primary care clinician, a case manager or a nurse clinician, a therapist, and a mental health specialist such as a psychiatrist. This is important because in psychiatry, each patient has many different needs, and some of these are really complicated, and no one individual can be able to adequately address all these needs of the patient by himself or herself. So, in terms of the treatment of depression, I'll talk a little bit about pharmacological therapy. I think at this point in time, psycho-oncology is still a fairly new topic, and because of that, research into that is still not that advanced. So in terms of the medications or antidepressants to use in patients for oncology patients with depression, there is still a lack of head-to-head trials. Head-to-head trials meaning comparing one active drug against another. At this point in time, most of the drug studies, if they ever deal with oncology patients, are more of drug placebo studies. And because of that, we do not have enough literature to say which is the most effective antidepressant. We would then only be able to assume that all antidepressants are equally effective. So at least for me, the choice of an antidepressant hence depends on a number of factors that the patient may volunteer to me. This could be the type of depressive symptoms. If a patient has insomnia from depression, then I'll consider a more sedating antidepressant, for example. If a patient has a lot of ongoing medical problems, such as dysphagia, because of the cancer therapy, then I'll consider another form of antidepressant, whereby the formulation is more easily swallowed by the patient. So, currently in psychiatry for antidepressants, we do have quite a few classes of medications. At least for a first line that we would use would be what we call the SSRIs, the selective serotonin reuptake inhibitors. These are common examples would be fluoxetine, Prozac, which has been around for decades, and escitalopram, which is something that I personally would prefer because of a lesser propensity for drug interactions. Bear in mind that the patient is already on chemotherapy agents. Other antidepressants that I may consider, but less likely so, would be things like tricyclic antidepressants. These antidepressants have been around for an even much longer time than the SSRIs, but I suppose I'm a little bit more circumspect in using them because they do come with a lot of side effect profiles. These will be anticholinergic side effects, meaning patients may be more predisposed to constipation or urinary retention, dryness of the mouth, and it may currently exacerbate some of the current issues that the patient may already be experiencing because of the cancer treatment. So others would also be something like mirtazapine. As mentioned earlier on, some of the cancer patients, they have problems swallowing. So if you give them a pill, it's not going to work because there's no way they can swallow. So the beautiful thing is about mirtazapine is that it also comes in the form of an oral dispersible tablet. So it's a little bit like an M&M. All you have to do is just pop it in the patient's mouth and it just melts, and then the effects will kick in. So other than pharmacological therapy, I think it is also important to look into non-pharmacological therapy. Commonly, we would do cognitive behavioral therapy, which is something that I would probably need my psychologist to help me to address some of the common themes of depression in oncology patients, for example. There exists quite a lot of support groups in my country where there will be patients or even the carers of patients meeting up together, sharing some of the experiences that they have struggling with cancer, and expressing solidarity with each other and learning from each other how best to deal with some of the day-to-day difficulties that they may experience while surviving cancer. There's also art therapy. A lot of patients often tell me that I can't draw, so I'm not going to do art therapy. So the thing about art therapy is that it is not art class. You don't have to be an artist to draw well to be able to participate in therapy. All it needs is a patient who's willing to doodle something and then discuss with an art therapist his feelings about his artwork, and from then on, the therapist will then work with the patient on some of the emotional difficulties that he or she may be having because of cancer. So I've talked a little bit about major depressive disorder. Now I'm going to talk a little bit more about delirium, okay? So delirium is a really important topic for clinicians who work in the hospital setting. It is also known as an acute confusional state, and it is important because it is a medical emergency. So commonly these patients would manifest as having an acute onset, probably just 2 or 3 days of confusion. They may not know where they are. They may think that they're at a supermarket. They may think that they're at home. They may not be able to recognize a doctor. They may think that they are working, for example. And other than it being of an acute onset, it is also fluctuating in nature. So meaning there will be times when the patient seems perfectly normal. He or she would know that he's in the hospital and you are the doctor or the nurse. But maybe the next hour later, he may think that she's elsewhere and she may not be able to recognize you anymore. So the concern about delirium is that it is often associated with very poor outcomes and very high mortality rates. And despite such a grave condition, studies have shown that the failure of detection of delirium in a hospital setting ranges anywhere from about 1/3 of patients to 2/3. So that's extremely worrying. So a take-home message to all clinicians is that because delirium is associated with such an increased risk in mortality, it should always be considered as a top diagnosis whenever a clinician sees a patient who is acutely confused. So it is at this point in time that I wish to debunk a second myth that I see happening quite often, at least in my place of practice. A common error among medical and nursing staff is to conclude that a new psychological symptom, usually confusion, is functional, meaning psychiatric in nature, without completely ruling out all possible medical etiologies. All right? So, briefly about the management of delirium. Some general principles need to be strictly adhered to. Because delirium is very complicated, it is important for the primary physician to liaise with other subspecialties. So commonly we will see the oncologist, who's the primary care physician, liaising with the psychiatrist, because the psychiatrist is needed to help prescribe medications to control the patient's agitated behavior. At the same time, the oncologist may liaise with, say, the infectious disease specialist, because a lot of patients, they will be going in and out of hospitals many times, and they will be in neutropenic sepsis, and the bugs that they capture or they catch while being admitted in the ward are really not easy to treat, and hence you probably will need an infectious disease specialist to help guide the best course of antibiotics to use to help treat the patient. It is also very important to be aware and also identify and treat the underlying causes of delirium. I say causes because delirium is usually multifactorial in nature. So commonly, some of these factors will be medications themselves. Some medications, such as those used for pain, such as opioids, are constipating in nature. And because of constipation, the patient may be more predisposed to urinary tract infections and hence get into sepsis. Other possible factors that can cause delirium could be also pain itself. So on the one hand, we would like to give the patient some opioid analgesics to help relieve pain, so that the patient won't get so much pain that he goes into delirium. At the same time, we are also worried that too much of it can actually cause constipation and hence another host of problems such as infections. So it really is not easy managing a patient with an oncology problem who's actually admitted to the hospital. At the same time, it is important to continuously and frequently monitor the patient's vital signs, while at the same time also be aware that if you do it once too often, you may actually cause sleep deprivation in the patient, and this would also actually worsen the delirium for the patient. Another principle is something where I'm actually involved in quite closely, which is actually to monitor and ensure safety. So the safety in this case is not just to the patient, but also to staff. So commonly we will see the patient, they will think that, say, even though it's at 3 a.m. at night, they will think that it is 8 a.m. in the morning, and they will not think that they're in the hospital, they think that it's time to go to work. So we commonly see these patients trying to climb out or being restless in bed and trying to climb out of bed, and sometimes that may lead to falls in the hospital, and this would cause unnecessary morbidity for the patient. At least for the safety levels for a staff concern would be the agitation that sometimes happens in the patient with delirium. They may not understand the need for blood taking, they may get agitated from the pain, and they may act out and hit the staff unnecessarily. Other things that we'll look into would also be to assess and monitor the psychiatric status of the patient, and also to provide psychoeducation to the patient. What it means is that it is a highly distressing time for the patient. He or she doesn't know where he is, and he experiences a lot of things that he usually wouldn't experience. Commonly, they may see things that we don't see. They may see snakes crawling around in the hospital. They may feel very scared. So it's important that the nurses or even the doctors would go to the patient commonly and frequently and sort of reassure the patient that all these experiences are not real. You're having delirium. This is because of some ongoing medical problem, and sort of reassure the patient so that the patient would not behave in an agitated manner. So non-pharmacological management is actually important in delirium, and it is something that I'll recommend as a first-line treatment for all patients with delirium actually. So on a patient level, it is very important to reorientate the patient by anyone who comes into contact with the patient. This could be the nurse, the doctor, or even the physiotherapist, for example. What reorientation is, it just simply means just tell the patient, hi, I am so and so, and this is a certain hospital, and this is Ward 64, for example, and today is Monday, and you're here because of this. And this is all that the various staff needs to do to sort of reorientate the patient and sort of like calm down the patient. So ideally, we would hope that we would not want to restrain the patient unnecessarily, because restraints do cause further distress to the patient. And we hope to mobilize the patient as early as possible, because immobility can also predispose to a whole host of medical problems as well. There will be also other nursing needs to look into: adequate hydration, enough fluids, enough oral feeding, pain control, address sensory impairment in those with visual or hearing problems. Imagine you're already very confused, you think you are seeing snakes in the hospital, and you have visual impairment. So can you imagine how scary things it would be if you have sensory impairment that is not actually addressed with some normal or simple visual or hearing aids. It's also important to communicate clearly and concisely with the patient. Nothing of long sentences or multi-step instructions, but just break down your communication into short, simple sentences because the patient is confused and would have difficulties trying to understand what you're trying to say. So, in an ideal setting, I'm not sure whether this is possible in the hospital environment, is to manipulate the environment a little bit. So, it would be great if there were limited room and staff changes, such that the same staff will be the same person attending to the patient most of the time. Providing a quiet patient care setting with low-level lighting at night so that the patient is able to rest well. Minimal noise also allows an uninterrupted period of sleep at night, which is important. I also recommend rendering the environment less alien by having familiar people and objects present to the patient around the bedside so that it has a calming effect on the patient. There are also some studies, and it's implemented in another hospital, not the one I'm working in, which is called bright light therapy. So in this therapy, what happens is that the patient is exposed to bright light in about in the period from 6 to 10 p.m. And we do not really know the reason why. It could be because of the changes in melatonin. We find that after the patients are exposed to this bright light from this period, they are actually calmer at night and they sleep better without a need for further medications. So interventions on a caregiver level would include encouraging the family members to come daily to see the patient, and also the communication as well from the caregivers, because sometimes they do not really understand what delirium is. So they'll talk to the patient as per normal, and as I mentioned earlier on, if the patient is delirious and has difficulty understanding you, the patient will probably have difficulties understanding the caregiver who speaks in long, lengthy sentences. That would be a bit too much for the patient. So pharmacological.
Finish in 1 minute, please.
Okay. So in terms of pharmacological needs, I'll just briefly talk about it. So the indications of it will be failed non-pharmacological interventions and when the delirium is extremely severe. So the take-home message for this is that we usually use antipsychotics, and this will be haloperidol and olanzapine. The thing to note would be that there is no difference in these two, and either or is actually preferential, is actually okay, and they are equally safe. I think we are approaching lunchtime, and maybe I'll just end my talk at this point in time. If you have any questions, you can feel free to ask me now.
Okay. Thank you very much for the very comprehensive information. There will be one short question for Dr. Tan. Any questions for him? Okay, yes, please.
We didn't address compliance in all of these situations. In Singapore, it's not a problem if the patient is depressed or delirious. It would probably affect his compliance in terms of the medication.
Compliance is a huge issue, and I think it's a huge issue in psychiatry, and actually it's also a huge issue in other aspects of medicine as well. With regards to compliance in a depressed patient, what we would usually do is we would try to explore some of the reasons behind the compliance. As mentioned earlier on, it could be the stigma of having being labeled of having a psychiatric illness. In such a case, what we could do is we could outsource our treatment care to another healthcare specialist that's not a psychiatrist trained, such as a primary care physician or a family physician who is actually comfortable with dealing with psychiatric medications and prescription. In terms of delirious patients who are not compliant, at least from where I practice, because delirium is a medical emergency, it is life-saving for certain interventions such as blood taking or medications to be given. In such cases, we would still go ahead with administering the patient with the medications, even though the patient may not necessarily agree to it.
Okay, thank you very much. Can I invite the co-chair to present the certificates to the presenters?
Thank you for your very interesting talk.
Thank you.
This is